So here are the reasons for denial or delay of FDA approval. So in this paper in JAMA, so by the way, you can find all of this information. FDA makes all the approval letters, everything available, and if you have the time, resources, you can track down this information. So what I wanted to point out is there are 4 bins in which FDA letters sort of indicate where the failures were. So the first class is efficacy, right? The trial just didn't show efficacy, and it fails approval because of that. Safety concerns. The other 2, I'm not that interested in as a methodologist. So these are chemistry, manufacturing, and control, CMC, and then labeling issues. So I'm not going to spend time talking about those. But look at so in this particular study, these were drugs that they examined, I guess, over a 10 or 12-year period. And you can see close to half, so there were total 302 drugs, half of them actually failed the first review. And unfortunately, 80 out of these 300 never got approval, all right? But let's examine among those that failed, 32% failed for efficacy, and you've got about 26% that failed for safety. And then you've got this combination of these poor 27 trials that failed for both efficacy and safety concerns. So as a methodologist, I'm thinking, what can we be doing in our earlier trials so that this is not the end result at the end of the day after all the hard work that has been put in? I think you'll remember this from the morning talk. Daria had this up in her talk, and you can see that it's not just oncology that experiences failures. Failures happen in all different classes, wherever areas of medicine you guys come from. But I want you to focus your attention on phase 2. And let's just look at, for sake of time, we just focus on 2011, 2012. You can see 59% failed due to lack of efficacy, and 22% due to safety concerns. Now, if you compare what's going on in phase 2 failures and the causes for phase 3 failures, the story is very similar. You keep coming back to lack of efficacy and safety concerns, right? And I think Daria talked about the strategic part. Like I said, you don't have much control over that, right? It's the drug company that decides, okay, well, we're going to tank this and not pursue it. But let's see what we can do and try to understand efficacy and safety concerns. So as we move into the next 2 sections, I want you to think about what could you be doing that would improve the internal validity of the studies that you're designing. Think about, do you have an appropriate sample? Do you have the appropriate outcomes that are clinically meaningful as well as reliable and valid? Do you have the appropriate study design? And have you considered carefully the analytic approach? So the whole idea is that we want to design a valid phase 1, which can inform a good phase 2. You want to come up with, at the end, a valid phase 2 that can then inform in a clear manner what a phase 3 should be. So moving ahead, let's talk about these specifically in the context of phase 1 and phase 2 trials. So in the first part of the second section, I'm going to talk about research methods that can improve validity in phase 1 trials. So why do a phase 1? Well, this is your first in human study. You want to determine the dose that will inform phase 2. You want to get an idea of the adverse event profile. And for those in oncology space, you're interested in sort of the maximal tolerated drug, right? That dose level, MTD, maximum tolerated dose. For those of you who are not in oncology space, sometimes, and if it's for pain or something, you may be interested in the minimally effective dose, right? What's the minimum that's needed that has sort of a not such a bad sort of risk profile? And usually we define, again, for those of you who are working on drugs that have severe side effects, the MTD is usually based on sort of your dose-limiting toxicity, right? And the idea is that the higher the dose, the better the therapeutic effect, but unfortunately, the higher the dose, the more the toxic effects. So you have to find that sweet spot where, where do I what dose is sort of going to have the maximum therapeutic effect, but won't have this horrendous toxicity profile. And then phase 1 is also about PK/PD. So as someone, I don't do PK/PD. I know many of you in the room probably are experts at this. But pharmacokinetics is what the body does to your drug, right? So how is it absorbed? How is it distributed? How is it metabolized? How is it excreted or eliminated? And then there's pharmacodynamics. So this is what the drug is doing to the body, right? So what are sort of the structure activity relationships and so on and so forth. So this is what, if I had to look down at the research process of a phase 1, this is what's going on. What am I interested in? I'm interested in PK/PD. I'm interested in determining the maximal tolerated dose. I have to think about, well, who are my patients? And this is important because you want to make sure that the patients in whom you're finding the dose are the ones that you're going to test in phase 2, right? If you've got a disconnect, how do you think that the dose determined in phase 1 is going to inform your phase 2 in a proper manner? What are your outcomes you're interested in? So what are your adverse outcomes if you're not in oncology space? This is a generic term for beyond, just worrying about toxicities. And then you want, again, the dose for phase 2. How? Well, Dr. Liu's talk that follows mine will tell you all design options to the best of his ability that he can do in an hour about how to design these studies. So very briefly, I just have one slide on this. And I'm sure many of you have heard of the traditional 3+3 extension design, right? To get to your MTD. Well, Dr. Liu will tell you, please, this is not the best, most efficient design, and try to use some of the others. So if you haven't heard of the others, you're in the right place because you will soon hear from Dr. Liu about the modified toxicity probability interval and CRM methods or continual reassessment methods, other Bayesian designs, and so on and so forth. Now, are you expected to know all of these? No. If I were designing a first-in-human, I wouldn't try to do this myself. I would go with experts who are available here on campus to help me design the best possible design, because I want to do it in an efficient manner, but at the same time, come up with a valid answer. And in this case, what's the valid answer? A reasonable risk profile. What are the expected adverse events or toxicities, as well as what is a dose that I'm going to go on and test further. These are other considerations to keep in mind when you're designing your first-in-human studies, right? So how do you define your dose-limiting toxicity? Where do you start for your first dose? How do you do the increments for your dose? How many patients do you need per cohort? What are your decision rules for dose assignment? What are your stopping rules? What are the method of analyses? A lot of questions that you have to really think about. And don't try to do this yourself. Work with the statistician early on and be prepared to answer all of these questions. That's sort of part of my message here. I can't teach you all of these in an hour, but to know that come prepared with these type of questions to even ask the statistician who may be helping you design the study. So let's ask ourselves the question, so why do phase 2 trials fail? We've seen some of the data. I almost think of the progression from phase 1 to phase 3 as a relay race. Yeah, it's not immediate. You're not done, within minutes. It takes years, 15 years sometimes. But here's the poor phase 1 trying to pass the baton on to the phase 2. And unfortunately, it fails. It's not a matter of pointing fingers whose fault it is. Both are involved, right? But let's see what we could be doing on the phase 1 end. So let's ask the question, efficacy. So immediately you're thinking, did I have the right dose? Did I determine the right dose in my phase 1? Did we treat the correct patient? Sort of when we went on and did the phase 2. Safety, how did we define toxicity? How did we measure it? So here are some real data. So I don't know how many of you think about reliability of the measurements you're using, but if not, I want you to think about that, because this you should absolutely know something about. So now here's an example of oncology. How do we determine dose-limiting toxicities? Well, NCI has their grading score, and in this particular study, I guess they have this other RTOG, the radiology specific one. The purpose of this paper was to examine the inter-rater reliability among radiation oncologists who are grading rectal bleeding. using two common scales. Okay, so intra-class correlation coefficient is one method that gives you a quantitative metric about this inter-rater reliability. Are you happy with these measurements? So 0.5 is at best moderate reliability, and 0.3 is not a good space to be. So this should be eye-opening. Now, why is this important? Because this introduces measurement error. So you design your study, you did your sample size, and then you don't find a signal. Well, some of this could be because you've got noise. And noise washes out the signal. So be thinking, what are the outcome measures that you're planning to use? Or in this case, how you're defining a bad event. And is this a reliable way of doing it? So going again to the question about, a lot of these trials were failing because of safety issues. So these guys wanted to ask the question, do early trials predict safety later down the road? So these are matched studies in the sense the researchers looked at all of the phase 1s that ultimately went on, and so you did a phase 3, and you wanted to see, did the early phase 1 trials capture all the toxicities that you were observing in the larger studies? And the basic point of this slide is that the good news is that 70% of the larger studies, right, the toxicities that were being described were captured in the initial phase 1. Again, these are the ones that sort of made it to the end. But what's important to note is that if your sample size for your early trials, like your phase 1 is less than 60, you do not capture all the adverse events that could happen down the road. But the minute you hit above 60, it captures most of the toxicities that you're likely to see down the road. So this is where there's a trade-off. If you've got really small numbers and you can get away with it, be cognizant. You may not have captured all possible adverse events that could come, sort of harassing you down the end and could lead to, not getting approval for your final study. The whole point again is, what about molecular targeted therapies? So these criteria sort of for adverse events and so on apply for cytotoxic agents. But for MTTs, the whole point of this slide is that toxicities continue to develop beyond the first cycle. And you can see the incidence of toxicities, both grade A through grade 4, continue to pile up over time. So people in the field are thinking for MTTs, maybe we need to rethink the criteria for toxicity, because some of these agents can produce moderate toxicities, but that can accumulate and linger on for a long duration. So do we need to rethink the paradigm? And I think there's a lot of work being done in the area of how to, and this is important because after all, MTDs are going to be based on these dose-limiting toxicities.